Thank you very much. Good afternoon, colleagues. So as an endocrinologist, my job is simple to just tell you about the importance of the glycemic control in patients with infected diabetic wound, the peripheral vascular disease, and it has got a good impact on the outcome of the procedure, whatever the procedure you have to undertake. You know, infection, healing, and the surgeon's choice of wound debridement is just like a snake and ladder. If you don't control the infection properly, healing doesn't take place, and ultimately patient lands up in amputation. The simple choice. So, unfortunately, the surgeons don't pay attention to the glycemic control. Only antibiotics is not going to solve the problem, and the infection will lead to worsening of infection, and infection will lead to the worsening of the glycemic control. So we need both emphasis on the multimodal treatment, and the key word is the teamwork, which is important, and we have been able to save a lot of limbs in our hospital because of our teamwork with the vascular surgeons and intervention cardiologists. We have been able to save many of the feet from amputation. Just a word of the epidemiology about the diabetic foot accounts for the largest number of hospital bed stays used for the diabetic patients, and around 1 to 4% diabetics develop foot ulcer annually. And studies have shown less cost for saving a limb for amputation. The main cause of hospitalization in patients with diabetes is basically the life-threatening acute metabolic complications, and primarily because of the uncontrolled diabetes and children or adolescents with newly diagnosed diabetes, in particular the patients with comorbid condition or the chronic complication. Now, coming to the cause of hospitalization in patients with diabetes, primarily patients with infected diabetic foot and patients with the peripheral artery disease, having some block here and there, where we take the help of our intervention cardiologist and the vascular surgeon. The hospital is related to the causes of the hyperglycemia. Illness-related stress can cause uncontrolled hyperglycemia, and clinically diagnosed hyperglycemia may be related to the pharmacotherapeutic agents which the patient might be receiving, parenteral nutrition, and sometimes associated glucocorticoid therapy. The common causes of the poor glycemic control is primarily when the hyperglycemia is associated with our diagnosis of pre-existing diabetes, which can result in higher mortality, admission to the ICUs, and overall poor outcomes. The primary reason for the poor outcomes is primarily because immunosuppression increased infection, platelet aggregation increases thrombosis, and increased cytokine levels at inflammatory markers, endothelial dysfunction, and increase in the oxidative stress. A cascade of metabolic events takes place in response to the metabolic stress, which releases a lot of stress hormones, causes hyperglycemia, low insulin level. There's a chain of metabolic events which leads to the increase in the ketone body production, free fatty acid secretion, lactose, and you can see a vicious cycle causing immune dysfunction, associated with immune dysfunction, increase in the oxidative stress, causing the prolonged hospital stay, disability, and the death. Early single percentage point matters, that even a 1% decrease in the HbA1c causes a dramatic reduction in the peripheral vascular disease. In hospital, blood glucose targets and regimens for obtaining optimal glycemic control is the key to have a good outcome. Pre-operative diabetes evaluation is must. You don't have to looking at the numbers alone, because hyperglycemia, even of mild degree, impairs food healing. Even the blood sugar random value more than 250 impairs the leukocyte function, prevents immunoglobulin from fixing complement correctly, increase the risk of mortality, and also the increased with the length of hospital stay. These are various components of a good glycemic control which overall improve the mortality rate, and these are some of the for the endocrinologists to know about how all it helps to have a good glycemic control. We often tend to do certain procedures where the patient is on oral hyperglycemic drugs. Primarily, we should avoid them and start using insulin as early as possible, because all these drugs take some time to have a good glycemic control, and they have associated some other problems like hypoglycemia, lactic acidosis, and sometimes the fluid retention. So insulin is the most effective treatment for inpatient glycemic control, and you have to know the adaptable to the increased insulin requirement during acute illness and infection. The basal insulin administration can prevent excess gluconeogenesis and ketogenesis, And often we tend to forget the importance of the basal insulin. We try to write only the sliding scale of the insulin, forget about the patient, and there's a ups and downs in the blood sugar values. Intravenous insulin is the first choice. You can have insulin infusion pumps, and you can adjust the dose of the insulin depending on the patient's blood sugar and the insulin requirement. I told about this subcut insulin therapy. When the patient is able to take orally, if the patient is not able to take orally, you want to shift from the IV insulin infusion to subcut insulin therapy. It is important, but mind it, don't be always dependent on the sliding scale of the insulin. Be pragmatic and give a multiple daily insulin injection, including at least one shot of basal insulin at that time. Because the sliding scale insulin just tell about that single point of the time what is the blood sugar values and does not take in account the overall glycemic control, and what you see is the roller coaster effect of the insulin sliding scale. So try to avoid the sliding scale of the insulin in your hospital settings. Subcutaneous insulin is very easy to start with. You can start with the basal component of a long-acting basal insulin like Glargine or the Detamir, and you can add the small doses of the prandial insulin or the short-acting insulin like Novorapid and Humalog, and titrate the dose depending on the blood sugar value. If you have pre-lunch high, try to titrate the morning dose of the short-acting insulin. If you have fasting sugar high, try to titrate the basal insulin dose. And when you are switching from the IV to subcutaneous, give a margin of at least half an hour to 1 hour before the subcut insulin takes over the action. You continue infusion, give a shot of subcut insulin, and then stop the infusion after half an hour or 1 hour. The second important thing is to avoid the hypoglycemia. Try to see that continuous or the frequent blood glucose monitoring is must if you want to have a good metabolic outcome. You have a lot of articles about the management of hyperglycemia in the hospital settings. You can choose any protocol, but the best protocol still remains the multiple dose of insulin injection using 3 shots of short-acting insulin and 1 shot of the basal insulin. In short, the aggressive glycemic management and follow-up of the hospitalized patients with elevated blood glucose is critical for the optimal glycemic control while in the hospital and also improves the hospital outcomes. Insulin should be used as the treatment of choice for optimal management of hyperglycemia in the hospital. Don't believe or rely on the oral drugs. And maintaining a tight glycemic control with IV or subcut insulin in the hospital can significantly improve the outcomes and reduce the direct and indirect costs currently associated with the uncontrolled hyperglycemia. Education, MNT, and the discharge planning are so essential components. We forget the patient, we have done an intervention procedure, we discharge the patient without educating how important it is to maintain the glycemic control. Patient goes home without knowing what kind of insulin. Here comes the important endocrine team which takes care of the patients and tell them with their diabetes educators what kind of insulin you are on, what kind of follow-up you require. That is must to have a better outcome. But often we usually forget the patient after discharge because the procedure has been done, patient is happy, doctor is happy, but what happens later on about the glycemic control, we have a very, very poor follow-up. And that is where there comes a role. We have a very good teamwork in our hospital with the vascular surgeons and intervention cardiologists. Sometimes primarily the endocrinologist admit the patient, send a referral to the intervention cardiologist or vascular surgeon, because at the time of discharge, our team is responsible for the follow-up of the patient for having a good glycemic control. Thank you very much.
Thank you very much for very illustrative description and advice regarding the management of diabetes in acute surgical conditions. Any questions, please?
Do these patients are, benefited with the use of sitagliptins?
Does this patient?
Do these patients get any benefit if we use sitagliptins?
No, because I told you they
not in hospital, outside the hospital.
Outside the hospital, there have been many studies where they have shown the combination of DPP-4 inhibitors along with the insulin. It only helps to cut down the insulin requirement per day of the patient is taking, and also if the patient is not happy with the parenteral insulin, taking 3 shots of insulin, at least you can give 1 shot of basal insulin and continue a DPP-4 inhibitor, which are very good candidates for controlling the post-parenteral hyperglycemia.
Thank you, Dr. Wagner.
Thank you.
Thank